I'm delivering our brief didactic today on substance misuse and use disorders in older adults. This actually was a bit of content. I've streamlined it a bit for our purposes here, but this was content that was requested for a geriatrics board review course recently. And so a lot of the content is more focused around sort of general practitioners seeing older adults in practice. And so looking at this through that lens to a certain extent. This is an issue of increasing importance. The geriatric population, population of older adults, sort of preferred term these days to elderly, expected to be well over 70 million in the next 11 years. And the current cohort entering older adulthood is very different from prior cohorts in terms of the prevalence of prior illicit drug use experience that many are carrying into older adulthood. And this is one of the most rapidly expanding health problems in the United States currently. So, you know, for those in treatment agencies, and particularly for those in primary care, this is something to have on your radar because it is something that's under-recognized. I think a lot of folks in practice see someone of older age who has grandchildren and may tend to think, oh, you're not possibly engaging in any sort of use that might be problematic. I don't need to ask those questions. And that's not necessarily true. But the other thing that I'm going to be getting into in a bit of detail with this is a lot of the problems that may be attributable to substances of potential misuse occur in a setting where the use falls short of an actual use disorder. Threshold for risk is lower in this age group, and so yet another reason to keep substance-related issues on the radar, because it doesn't take addiction for substance use to become problematic. And I'll be talking about that a bit more, talking a little bit about some trends and concepts here, and then get to some of the medical management issues for the things that are most common in this age group. Alcohol, of course, you know, aside from tobacco, and then the prescription medication issues, particularly opioids and sedative hypnotics being of particular prevalence and issue in this age group. When it comes to the population of older adults, well, when it comes to sort of all comers and we're thinking about the likelihood of the misuse of substances or addiction, there are some risk factors that we keep in mind for sort of all comers age 12 and up by way of things that confer risk. And a lot of this is similar for older adults, but there are some of these factors that are particularly strong predictors for substance misuse and perhaps even use disorder. Bereavement or depression, being a caregiver for someone with significant disability, and where relationship perhaps hasn't been as strong for younger adults, sort of spiritual community, spiritual practice, and to what extent that's confounded by the loneliness, social isolation factor is a little unclear, but those are some things perhaps warranting particular focus in this age group by way of risk. And these, as opposed to risk factors, are some of the indications in clinical practice you might see where taking some degree of a dive into substance use might be important. One of the most common here is falls and injury that might be attributable to, again, not necessarily use disorder, but perhaps an episode of use that we might even not think of as being risky for a younger individual. Maybe more so for individuals in the older adult age range. And some of these other things may be a bit more sort of common sense by way of when I would think about taking a deeper dive into substance use, impaired self-care, having seizures that haven't been part of history previously, various forms of cognitive impairment or mood fluctuation or disorder. May also be indications that substance misuse or use disorder exists and should be assessed in some detail. So putting up by way of review the recommended limits for alcohol consumption in general from the National Institute on Alcohol Abuse and Alcoholism, to provide the reminder that I think a lot of folks in general care will remember that we look at standard drinks, and I've got those depicted here. Important to keep in mind that when we talk about these guidelines and number of drinks, it's referring to these standard drinks, and not just when a patient says, I have 2 mixed drinks a day. Odds are that often that's not a standard drink. If they're mixing it themselves, they're probably not meticulously measuring out this 1.5 ounces of spirits and having a truly standard drink. So that's one point that I'd make there. But by way of weekly consumption and what constitutes a binge, it's similar. The recommendation is similar for women over the life course, but it makes a change at age 65 for men, where men under 65, 5th standard drink constitutes a binge, and more than 14 standard drinks in a week constitutes risky use, but that changes after age 65 in the NIAAA guidelines to come into line with recommendations around consumption for women, with a 4th standard drink becoming binge, and 7 or less in a week being the recommended limit according to the NIAAA guidelines. Some of you may be familiar with data that might lead us to question these guidelines. For example, we know that even these moderate levels of consumption are associated with increased risk of breast cancer and are associated with perhaps some degree of cognitive impact as we age, if this moderate consumption is engaged in on a regular basis. And that was one of the most widely cited studies of 2017, where older adults consuming in this range were found to have some impact to a statistically significant degree on lexical fluency or word finding. The extent to which that's clinically significant or conferring functional impairment is another issue altogether. But that's all by way of saying that we may want to be thinking about tailoring these guidelines, particularly for older adults, and couching it in some terms of their personal history and perhaps their family history in terms of risk for some of these things and the extent to which even moderate alcohol consumption might increase that risk. So this is a diagram that many of you may have seen before, depicting levels of potential alcohol use from lowest risk or abstinence at the base of the pyramid, moving up through low risk use, harmful or high risk use, meaning drinking outside of those recommended limits, but perhaps not meeting criteria for an actual use disorder. And when we engage in our screening, we're trying to catch things short of alcohol use disorder and more in this harmful or high risk use for younger adults. But as I made mention of earlier, we have some indication that even lower risk use may confer some risk for older adults. And we'll be wanting to keep our eye out for perhaps lower levels of consumption and risks that might be associated with that. And when we're screening, and you know, this is not just true for older adults, this is true for other populations such as women of childbearing age, perhaps ethnicity. The screens with which we're quite familiar may perform differently depending on the population in which they were tested. And you can see here that these instruments seem to perform a little differently for older adults, where the cage doesn't work particularly well. That's a questionnaire that I think our healthcare learners get fairly familiar with. It's the 4 questions. You thought about cutting down on your use? Are you annoyed when confronted about your use? Feel guilty about it? Or do you require the E and eye opener or use in the morning to calm your nerves or function during the day? The alcohol use disorders identification test, and even that's a 10-item screener. and even its shorter version, the Audit C, actually seem to perform fairly well in older adults as well. And so if you're in a setting that's already using Audit C for all comers, it's probably fair to say that sticking with that is reasonable by way of a screen. But there are sort of tailored screens for older adults that may have some advantage by way of their testing characteristics. And interestingly, when we look at each of these, and the items have been dug into a bit, the items that seem to be the most sensitive for detecting risky use or perhaps use disorder are actually the binge questions. And so, for example, on the 3-item Audit C, it's this 3rd item that seems to perform particularly well for older adults. How often, and in the course of the Audit C, they actually use a somewhat different definition than we see in the NIAAA guidelines, but this seems to be the one with strongest association. So in the course of assessment, even if you're talking to older adults about the frequency of higher levels of consumption or whether or not it happened over a period of time, that perhaps is a fairly effective screen. So as we've gone through screening, done further assessment, and perhaps landed on the impression that the older adult has an actual alcohol use disorder, one of the considerations and the recommendation is to offer at least pharmacotherapy to anyone that meets those criteria for the use disorder. And these are, so the FDA approved agents are up there, of course, naltrexone, acamprosate, disulfiram. The other agents that you see there have some data to support their use, so they aren't FDA approved for that indication. There is good evidence from well-designed randomized controlled trials indicating that they may have some value. There are some considerations for older adults when we think about contraindications potentially for these medications and whether we should think about using them. So disulfiram, for example, is one we probably should not be thinking about as first line for older adults due to the fact that the disulfiram alcohol interaction that we kind of depend on to dissuade folks from using alcohol actually has been associated with sudden cardiac death. And we're talking about a population with greater cardiac risk. So this is generally not thought of as first line, and the American Geriatric Society recommends against its use in this population. Baclofen has been getting some attention, particularly internationally, as an agent for perhaps even maintenance in this setting. It comes with a fair list of potential concerns, even for younger individuals, since it is also a GABAergic agent like benzodiazepines, like alcohol, and therefore the physical dependence and the withdrawal can be similar, progressing even to seizure and life-threatening circumstances. But it also can be a fairly sedating medication that may interact with others. We're talking about a group of individuals at risk for being on more medications, and so that interaction, as well as those other factors, make this likely less of a consideration, particularly for older adults. Similarly, topiramate, many medication interactions risk for acidemia and organ damage subsequent to that. And so gabapentin, some sedating effects that may interact with other medications that this group may be on, worth considering, but that's a caution when thinking about gabapentin, thinking about using it in lower doses with more careful monitoring. I put up this bullet point: treatment outcomes in older adults look very similar to those in younger, because I think a lot of clinical providers may have the preconceived notion that someone who has reached older adulthood has a use disorder. Oh, they're set in their ways. I'm not going to be able to do anything to change this behavior. Data actually indicate otherwise, and folks that get directed to the treatment that's indicated tend to do as well as those who are younger. There may be some advantage to directing them to elder-focused treatment programs, but access to these programs is fairly limited, so that can be a challenge. And it may be that the resources available in your area don't have that available, but but we're checking out. Some senior centers will have groups that may be elder focused or focus on an elderly community that patients in the older adult cohort may feel more comfortable connecting with to address the issue. So far as prescription medications, this is an interesting area. The dynamic changes a bit when you talk about prescription drug misuse, be it opioids or benzodiazepines, when you get to older adults. Again, I was emphasizing earlier that use falling short of movement toward a use disorder, or use disorder itself may result in negative consequences such as falls. And when something like that happens, or when physical dependence or use disorder develops, most of the time it's actually unintentional. Most of the time they're getting these prescriptions from a provider that they see with some regularity, as opposed to younger individuals perhaps misusing these medications where the more common source is outside of a patient-provider relationship, and they get the preparations from family members or friends. Older adults are at more risk of exposure to these medications because they have more clinical contact, there are more pain-related visits. Benzodiazepines, unfortunately, continue to be quite commonly prescribed with fair regularity, even to be recommended taken up to on a daily basis, leading to this set of issues around unintentional misuse, unintentional sort of consequences related to use, even if that's use at a level that was recommended by a provider. Other factors to which I've also alluded to some degree, this population very frequently on more than one medication. 30% have 5 or more prescription medications, so that comes with risk for medication interaction. And then due to physiological changes as we age, elimination of these substances slows, and this combination of factors leads to greater likelihood of potential consequences such as accidental injury and health services utilization. So there are fairly well considered and evidence-based guidelines around screening for at-risk alcohol use and alcohol use disorder. When it comes to risky and problem use of other substances, data is limited and consensus has not yet been landed upon. But the second bullet here points out one study that looks fairly promising, looking at the validity of the severity dependence scale in a sample of older adults, where the area under the curve for the receiver operating curve was 0.86. What's the area under the curve for those not familiar with that term? So that's a number that's arrived at by looking at the sensitivity of the test, or the likelihood that the test will be positive in the setting of disease, and the specificity, or the likelihood that the test will be negative in the absence of disease. And those get plotted on an axis, and if the sensitivity and the specificity are perfect, then you get an area under the curve of 1.0, perfect sensitivity and perfect specificity. So 0.86 is pretty darn good when you consider that the area under the curve for mammography for breast cancer is about 0.6, which is very commonly recommended health maintenance screening intervention. For opioids, as you might imagine, prescription opioid misuse, much more common than illicit opioid misuse. Unintentional misuse and physical dependence arising from recommended use are more common than intentional misuse, recreational use, use for purposes of achieving intoxication. And the source of opioids that are misused are much more commonly a prescriber than other illicit sources. And so if they are prescribed, it's very important to engage in careful counseling around how they should be taken, potential indications that they may be too risky for the individual, counseling around appropriate storage and environment, consideration of storage that may guide how to take the medication, such as pill boxes, things along those lines. The other piece to this, by way of the population health perspective, I made mention of the fact that the majority of younger adults who misuse opioids, for example, are getting them from a family member or a friend. And it's not uncommon for older adults to be victimized for these substances by such individuals. So that's the other reason it's important to talk to older adults who, in some cases are going to need controlled substance medications for their quality of life. So important to engage in this careful counseling around their handling to minimize potential risk to themselves as well as to the surrounding community. Most are likely familiar with CDC guidelines around considerations for opioid prescribing, and those look fairly similar when this may be a consideration for chronic pain management for older adults, but there are a few wrinkles. Long-acting opioids more frequently associated with overdose, so if they are started, important to start with lower doses of shorter acting agents. A number of providers think of tramadol and pentadol related agents as safer in some sense, but it's important to remember that these are still opioids, and in the older adult population, they're still associated with fall and fracture risk, and risk for delirium is actually higher for these agents than it is for the more typical opioids. And there's been some conjecture in the literature, is this being put out as first line, all comers? Not necessarily, but worth the consideration of buprenorphine perhaps earlier for pain management in the population of older adults, since it is less sedating, and the prolongation of half-life that you see with other controlled substances potentially isn't something that you see so much with buprenorphine. And then, of course, methadone generally is to be avoided by way of a pain management agent in this population due to its fairly unpredictable metabolism and risk for QT prolongation and mortality. In touching on the guidelines around pain, the CDC guidelines that most of you have some familiarity with, CDC has recently come out with statements regarding caution against misapplication of the guidelines, that opioids can still be part of the toolkit for pain management, and that if someone is on higher or riskier doses, we should be thoughtful and gradual in our taper efforts, as opioid withdrawal is horribly uncomfortable, and is and beyond that has been associated with suicide, particularly in veteran populations. So the target being below the moderate risk cutoff according to the CDC guidelines, under 50 milligram morphine equivalents daily if possible. Going slow with the taper as long as they're maintaining forward progress, not engaging in aberrant use, maintaining some flexibility around the rate of the taper, providing support in terms of adjunctive medications, and really regular follow-up. To provide some counseling and a prescription for a month's worth of a taper probably isn't going to work as well as more limited supplies with each step of the taper and moving forward. So the benzodiazepines, the most common psychiatric prescription medications among older adults, frequently prescribed for insomnia and anxiety, and sometimes on an ongoing basis, which may be unfortunate given the fact that older adults are more sensitive to the sedating effects of these medications, and at greater risk for adverse effects, again, such as accidental injury, falls, and fractures, which can be life-threatening, right? I mean, hip fractures have mortality rates that are not insignificant. And I've already made mention of a number of these things, and so I'm clipping along as I see we're getting close to the end of our hour, but I've touched on a lot of this already, and I think a lot of it is fairly intuitive when we know about the sedating effects of benzodiazepines and interference with coordination, reaction time associated with these falls and fractures, may be associated with symptomatology that looks like delirium or dementia, and their ongoing use, even if done as prescribed, is actually associated with increased mortality risk. So something to be aware of. So as such, the American Geriatric Society recommendations in their last two versions have generally recommended against the use of benzodiazepines, particularly on an ongoing basis. And if an older adult is admitted for a fall and benzodiazepine has been prescribed previously, that's certainly something that warrants reevaluation and likely discontinuation. In the most recent update, the non-benzodiazepine receptor agonists, or Z drugs, such as Zolpidem or Ambien, are viewed similarly, which is new from past guidelines. Tapering benzodiazepines is often really challenging for patients. They can find it very difficult to move forward and discontinue these agents. And there's a somewhat complicated table up here that I don't think you need to take pains to memorize. It's simply illustrating how gradual a successful taper might be, to get folks through this without experiencing the withdrawal that can be really uncomfortable and complicate the taper. So some providers will use some adjunctive treatments in the course of benzodiazepine detoxification. And in the population of older adults, there aren't a lot of data indicating that we should strongly favor some particular adjunctive agent to make the taper more likely to be successful. Some indication that lower doses of doxepin may assist in managing the insomnia that can come up and be problematic for patients during the course of the taper. Cognitive behavioral therapeutic modalities have looked to do particularly well in prospective studies. Some of these other agents we might consider early may confer greater risk in the older adult population, and so warrant fairly careful assessment and monitoring if they're considered for management of the depression or anxiety in older adults. I know we're running just a touch over, but I wanted to put this up because this was a call that I actually just got yesterday. Or actually day before yesterday, that seemed to be particularly pertinent here. A provider emailed indicating that she was following an 80-year-old patient that was new to her, had substance misuse issues in the past. Those weren't fully characterized, but she was taking 0.5 milligrams of alprazolam or Xanax and 10 milligrams of oxycodone. So the alprazolam 4 times a day, oxycodone 5 times a day, and was engaging in some demands of the clinic and some behaviors that were challenging to the clinic around the medication, running out early, quote, violating management agreements with the controlled substances, and so had called with some advice around tapering these medications. So for those still around, this is really kind of the end of my presentation. I was hoping we pause there and just see if there are folks who sort of have their own ideas about approaching discontinuation if they discontinue these medications in a patient that looks like this.
This is Sheila.
Yeah.
This particular patient, I'd recommend an inpatient detox, reevaluation of her pain and other needs, and then retitrating to whatever she needs. Because again, the risk you have, she can't follow contract. Why is she going to be able to follow a taper? Plus to verify, is she taking all of those meds or are they being taken by someone else?
Yeah, good point. Yeah, that'd be good.
Because again, she's a potential vulnerable adult.
Right, absolutely.
I do have one other point, not particular to this case. I would encourage people to not let a halo ageism get in the way of what they're looking at. Because I can tell you with the baby boomers, of which I'm a proud member, where those are 46 to 64 is when they were born, and they are now in this group. Many of them go back to the drugs they used when they were young, after retirement and stuff. So I get people who tried methamphetamine last week for their chronic pain.
Right.
We've also had a patient with delirium that what it came down to is he was smoking wax. So highly concentrated marijuana. And once that was removed, he actually ended up under guardianship. He is back and functional. So do not let the concept of other drugs enter in because it's an older person. It would only be alcohol or benzos. Oh, heavens no.
Absolutely.
From another angle for the pain issues, if she is actually, I like the idea of tapering her off everything for this particular case,
Right.
and then trying to figure out what she needs. But as a if you're worried about diversion, that like the Butrans patch is a nice one because
Right.
it's once a week, it's on, you don't have to worry about it. If say she's getting any home health or anything, that person could be the one to put that on. There's just a lot of opportunities, it sounds like, for this woman to have more wraparound services, maybe to help with med adherence, figure out other things. If you're going to end up doing a outpatient taper, obviously alprazolam short acting, switching to clonazepam and doing some sort of a structured taper. But I agree with Sheila, she's probably not going to be able to do it, and the risk that she'll proceed to find meds on her own. It's just hard to imagine necessarily an 80-year-old woman going doctor to doctor or to other people, but obviously she's already done it once. There's no reason that it wouldn't happen again. So finding a way to take the medication out of her hands for the taper, or doing shorter refills, making her go weekly to the pharmacy, that kind of thing, if you're gonna do it, would make the most sense.
Yeah.
Plus, did they mention if they did urine to verify it's in her urine?
No, she did not. This was a written communication. I didn't have interact to get more information yet. So.
Randy, this is John. I'm just going to be the voice of the co-use of alcohol. I'd be really worried about that as well.
Oh yeah, right. Absolutely.
Underlying reason why she was getting the opioids in the first place?
I don't have the diagnosis yet. No, I'm still needing to actually interact over the phone with this provider. So I actually reached back to try to connect, and I'm hoping she'll come back to this group with a presentation and some follow-up too.